My name is Holly Teagle, and I am the Clinical Director of Audiology and Habilitation at the Hearing House, and also an Associate Professor in the Audiology section at the University of Auckland. And today I'm going to talk about a program that we've developed at the Hearing House, a clinical program that has some exciting research implications for us. It's called a CMV specialty clinic, and it's a pilot program that was developed really out of the interest of some of the clinicians that work with the children who have cochlear implants, and it was supported by a grant from the Freemasons Foundation. So Cytomegalovirus, which is shortened as CMV, is quite common, and yet even though we've been aware of it for many, many years, several decades, it's still not very well known among mothers and children who are most affected by it. So it turns out that cytomegalovirus, CMV, is the most common cause of non-genetic congenital hearing loss. And it's a virus that the mother is exposed to during pregnancy, a herpes family virus that is spread through bodily fluids. And if the mother is exposed to the virus during pregnancy, it can have some really significant and serious implications for the baby. The symptoms of the virus itself are not unlike a cold. It may involve a fever, runny nose, but depending on the gestational state of the baby and the severity of the infection for the mother, it can have, again, really severe impact on the developing fetus. So about 90% of the babies that are born who have been exposed to CMV in utero will be asymptomatic at birth. The 10% that are symptomatic tend to have a rash and a body rash, skin rash, and may present early and really are quite sick babies that always end up in the NICU. Hearing loss is a common cause or a common effect of the virus, and it can manifest in a lot of different ways. It's and is quite unpredictable. Usually, if a baby is symptomatic, it would be screened at birth, and the blood from the heel stick would be used to confirm that the virus was present in the bloodstream. But if the baby's not symptomatic, there may be no reason to take the time to test at birth. However, you can go back and look at the Guthrie card, which is the blood spot that's obtained for all newborn infants, and analyze that to see if the virus was present. So it can really only be confirmed as a congenital affection through testing that's done right at birth or with the Guthrie card afterwards. The hearing loss can manifest as bilateral or unilateral hearing loss. It is typically sensory neural and can be any degree or configuration. So we see children who present with mild hearing loss, severe to profound, and for many of the children it is progressive. So even if they may not be, if a child has a CMV infection at birth and it's asymptomatic, and then we see the newborn hearing screening can happen, and they may not be picked up at that point if the hearing loss has not progressed, but it can actually progress within the first few months of life and result in a significant hearing loss. So it can be a little tricky to generalize about how it presents in terms of hearing loss. There's all different variations there. It ends up that about 10 to 15% of the asymptomatic infants and a larger percentage of those who are symptomatic will have hearing loss. And in addition to hearing loss, there are a number of other health issues that manifest. These can be developmental delays that are secondary to neurologic disorders, neuromuscular sequela, vision loss, cognitive disability, a small head size, seizures. So it can have very significant neurological impact on the baby. And the extent of the impact is hard to predict, because just as hearing loss can be progressive, some of the other symptoms can also be progressive. So it's always interesting to me to know how aware young mothers are of this virus, and in talking with colleagues and students and sharing this kind of information, I'm always surprised that a large number of people have never heard of the virus, and it's not typically screened for during pregnancy. And it's really only if a mother has some knowledge of it that she might think to have a blood test to see if she's CMV positive before pregnancy, and to see if she's been exposed to the virus during pregnancy, so that so a family could plan if they know they had a CMV infection exposure during pregnancy. So a general awareness about the virus, even though we do know a lot, there's a lot of literature that's been that addresses the outcomes of the effects of CMV. We still are not doing a very good job of keeping public information up to the level that it's more common. There is common understanding of it, and really the kind of precautions that are needed are quite simple, because it's a virus that's transmitted with bodily fluids. It really involves hand washing, not kissing on the mouth, not sharing food utensils, things like that. They're kind of a lot of common sense things that a mother can do during pregnancy to try to avoid the impact of it. So children with CMV often have, in addition to hearing loss, a number of other medical diagnoses. And again, there's quite a lot of literature out there that explains this and follows some of these symptoms. Hearing loss has been one of the primary areas that, of course, that I've been interested in. But when we see children who have hearing loss secondary to CMV, it's quite obvious that they also have other developmental issues. And these can include a lot of things that are symptomatically mild, such as some respiratory problems or migraines, to more significant issues, cognitive delays, general developmental delays, physical movement difficulties, balance, visual issues, and many of the children that I have seen who end up with hearing loss and maybe eventually cochlear implants end up having a diagnosis of, on the autism spectrum, sensory integration issues, attention deficit disorder, a lot of other neurological related issues. And many of the children have actually more than 2 additional diagnoses besides hearing loss. So it's a very it's complex, and it's surprisingly common, and it's something that it came as an interest to the Hearing House, because we have a number of children who the cause of hearing loss is CMV, and just trying to manage them, all their needs. We came up with the concept for this CMV specialty clinic. So, a team approach for a child with multiple needs has been shown to be efficient and satisfying to parents and caregivers, but it's really difficult to coordinate all those special needs for one child. A family may end up going to a pediatrician in one place, an OT or PT in another place, a feeding specialist, audiologist, speech pathologist. Really, the care can be quite disconnected and difficult to manage, just the logistics of a family trying to manage all the special needs of the child. So our thinking was that if we could really address the whole child in one setting, and use our wonderful facilities at the Hearing House to stage this clinic, that we could maybe have an impact on the quality of life for these children and their parent satisfaction in the kind of medical treatment that they're getting. So we took the opportunity and with the support of the Freemasons Foundation, put together a program that we hope to meet these needs. And, in addition to doing a multidiscipline evaluation of the child, we wanted to facilitate parent networking and give families an opportunity to share knowledge, share stories, develop friendships, and all the benefits that come from belong to a community where you can get support for your child and your family's needs. So most of the children, of course, that we see at the Hearing House, since we are the Cochlear Implant Center for the northern part of New Zealand, most of those children have moderately severe to profound hearing loss. But certainly there are a lot of children that have lesser degrees of hearing loss that do not come into our service, that are out there, and our hope is that at some point we can continue to identify families, children who are not just cochlear implant recipients, but maybe hearing aid users that we could also include. But when we did a review of our current, the children who are currently in service at the Hearing House, there were 22 children that had a confirmed congenital CMV diagnosis, and that was about 10% of our overall caseload. 8 of them were under 5 years of age, and 14 were over age 5. There was a variety of hearing loss patterns. Some were unilateral, some were asymmetric, bilateral. Some children were using bilateral implants. Some children had an implant and a hearing aid. 3 of them had a documented progression to hearing loss. 1 has cochlear nerve deficiency that is sort of another layer of difficulty. And there could be more children. We didn't include children that we weren't sure had the diagnosis. So there may have been children who were positive and their blood spot Guthrie card had not yet been checked, and so we haven't actually included them in this group yet. So there's potentially many more children that could be affected that in our service. So thinking about this as a team, we wanted to provide a collaborative, multidisciplinary approach, and there are a lot of ways to look at that. Multidisciplinary, bringing in people from several different disciplines, but in many ways the goal was to create an interdisciplinary team so that we're working together. It's a work in progress, but this is the model that we've used. So the team members that we've involved are an otolaryngologist, a developmental pediatrician, audiologist, speech-language pathologist, occupational therapy, physiotherapy, a pediatric nutritionist, and an educational psychologist. And so we reached, and we don't have all these specialties, of course, within the Hearing House. So with the help of the otolaryngologist, we reached out to a number of other professionals in the community and invited them to participate in this pilot program. And we had a really remarkable and positive response from them. Everyone was aware of the need and interested in helping. So we formed sort of an extended team of people, and to put to get the program off to a good start, as we were planning, we thought it would be wise to start by conducting a workshop for families so that we could bring everybody up to the same level of knowledge and And then the plan was from there to go on to do individual assessments of the children and in a group, in an individual and group setting, and then make recommendations as a team for that particular child. So really, giving us the opportunity to bring families together, do that networking, that sharing, and that support, and then breaking down into individual assessments later. So the workshop was organized on a Saturday, and in May, and we had 7 families participate. They all came to the Hearing House, and we had a variety of speakers throughout the day, and opportunities for sharing and eating together. The children that came had support from students at the university to help entertain them, and it was a really great day of sharing and information. This word cloud that you see here was an outcome of an activity that we all did. All the parents in the course of the day were writing down just their thoughts and emotions as they were learning new information about what CMV and what the impact of it is. And these are some of the words and phrases that they came up with. And we've used this as a little bit of kind of a logo for the CMV clinics now. So I think some of the words that you see there are really meaningful and express all the variety of emotions that parents feel when they're dealing with this diagnosis and trying to understand it and how it impacts their child. So the workshop, the reason for the workshop was to recognize the special needs of these children at the Hearing House who have CMV and provide a team approach to diagnosis and treatment. Then give families and their caregivers a voice in management decisions and just sharing of their child's strengths and challenges, and so that we could develop a mutual understanding among the parents and the health providers of what the child's need, sort of paint a picture for each individual child. And then network both among our parent group and with our professionals to share and support, and then transition recommendations into practice. So, and again, this is a pilot program, and our goal was ultimately to see each child and put together a set of recommendations and practices that the family could act on, and then follow up later in several months to see how that was going, see if there were adjustments or changes that we could make. But again, it was a little bit of a novel approach to managing all these various needs that each child had. So the agenda for the workshop, we had the families introduce themselves and their children, and Colin Brown, who's been the surgeon for many of these children who had for their cochlear implants, did a really nice overview of what CMV is, how it's transmitted, what treatment options are available for it, the pros and cons of some of those treatment options, how it manifests over time as a child grows, just a nice clinical overview of what CMV is and how it relates to hearing loss. Rosemary Marks is a developmental pediatrician who's been in Auckland for many years, and many people know and love her. She did a really excellent presentation on what CMV looks like at different stages in terms of a child's development, and offered parents lots of encouragement and support. So from a pediatrician standpoint, Claire Kinnera and Denise Boss are employees of the Hearing House. They're speech-language pathologist and audiologist, and they provided an overview of what the population at the Hearing House looks like. The afternoon speakers included Lucy Charles, Rural Hamill, who are OTPTs in the Auckland area and have a private practice and have seen while they hadn't seen any of the children on our caseload, they were familiar with all the symptoms and signs of CMV infection, and so they brought a lot of information. Sandra Smith is an educational psychologist, and she not only shared information about what's involved in an educational psychology evaluation, but talked a lot about ongoing grief and sorrow that sometimes comes with a child who has significant developmental delays, and how, as a child transitions through life, these different aspects of the condition can impact life in different ways. So a lot of good support there. I finished up with sort of a plan for the next steps of our program, and we did some parent questionnaires, and then ended up with a really nice social hour to let parents have some time to get to know one another and the providers a little bit better. And Megan Levi was our staff facilitator for this workshop. So it was a day long. It was really turned out very well. I'm going to share some of the data that Claire and Denise shared with families during the course of the workshop, and they reviewed the population at the Hearing House. So all of these children had at least one cochlear implant, but some of them had a hearing aid as well in the opposite ear. And for the most part, from a hearing standpoint, the benefit that an implant provides, or hearing aids provide, for a child with CMV is similar to those children who have hearing loss that's not secondary to CMV. So the technology works well for them. It can overcome the sensorineural hearing loss. So from a hearing detection and hearing awareness standpoint, the children can get very good benefit from cochlear implants and hearing aids. What is more impactful is some of the secondary conditions and how they affect the child's development and cognition. So there's a great deal of variability in outcomes for children with CMV and their cochlear implants. Some of them develop spoken language and approach the same abilities as their hearing peers. Others make continual progress with spoken language, receptive and expressive language, but may need to use additional cues and support to make progress, and may not quite meet the same developmental milestones as their hearing peers. So there's a lot of reasons for why the variability exists. Some of it is simply just due to the child's other challenges, and then again those underlying language cognitive delays. So it's kind of hard to summarize it all in one as one whole. They're each individuals and have unique outcomes. And again, they use a variety of communication modes. We have children who use New Zealand Sign Language, spoken language, or some kind of a combination of the above, and even children who are using augmentative communication, PICS, picture system, picture cards, things like that. So have to really look at each individual child and what their strengths, challenges are when we're making decisions about communication mode. These are some of the language scores that Claire polled on the children on the cohort at the Hearing House, and just a real general picture of language outcomes on two different tests. The standard score is shown anything between 85 and 115 is considered the normal range for a standard score, and the children in the gray boxes are children that have cochlear implants that are and hearing loss that is not secondary to CMV infection, as far as we know, and the blue are those children who have hearing loss due to a CMV infection. So we do see the impact of the virus and sequela that happens on language outcomes. And the other interesting point about the children at the Hearing House is that many of them require additional supports beyond the speech and language services that they receive with us. They have ORS applications in place, so very high needs, 40%, or 27, or 40% for very high needs 27%. And then we have some children that haven't actually gone through that process yet of deciding if ORS support is going to be necessary. But in general, that as a group, it's just another example of how their additional challenges create the need for additional support. And why, another reason why we thought this cooperative program, this clinic, would be important to these families. This is some of the, these are a listing of some of the clinical observations that the different habilitationists at the Hearing House made, just observations about language behaviors that they observe. And I think a lot of the parents in the audience were very interested in this because they were starting to understand why their child was doing some of the behaviors that were unusual and that they thought were unique to their child. But we know that children with CMV have differences in their word learning, how they access vocabulary, how they use words, what their receptive and expressive understanding of the words. So there's certainly some impact of language and vocabulary. Executive function is another area that we see differences in children with CMV. Impulse control, attention span, working memory. Children with CMV sometimes are hard to engage in a task. It's hard to maintain interest in a task. Some of them seem to have sensory integration issues that make it hard for them to learn. And sometimes those sensory integration issues and developmental delays can lead to sort of secondary emotional behaviors that are maybe atypical from a normal developing child. Their ability to use words and phrases to combine them and have a whole language is different. Their grammatical development is different, so in their written and spoken language. Other observations that we've made and others have documented in the literature is that processing time and their ability to manage stress and more information coming from more than one source can be challenging. New words, learning new words, new concepts, and then just relating to other children and adults and in different environments can be challenging. Speech production also can be different as a manifestation of that. So some of these things are probably directly related to hearing loss, but many of them are likely not secondary to hearing loss. They're really more due to the underlying neurological issues that resulted from the CMV. And I think many of them, again, they're hard. Some of these are hard to document, and so therefore kind of hard to work on in therapy, hard to remediate. So the summary for Claire with her overview of our cohort at the Hearing House was that listening was not the greatest barrier to communication, and even though all of these children were in our caseload because they had cochlear implants and hearing aids, that listening was not the greatest challenge for them, and that there really is a difference in the way that children with CMV learn language and use language. Early intervention is important and ongoing support is essential, and that we're really just beginning to understand some of these various aspects of language development and how that diagnosis of CMV has impacted that. So there's still a lot to learn in this area, and there is some active research going on around the world, And we would like to be able to contribute to some of that. So we did some pre and post workshop querying of the families, of the parents, just to see if we were on the right track with sharing information. And so just a little survey of what their understanding or awareness was of the causes of CMV, the symptoms of CMV, what medical services were available to them and their child, what occupational and physiotherapy services look like, and what an educational psychologist could provide. And you can see from this simple graph here that on a scale of 1 to 5 that all of the families in general showed that they learned a lot from the one-day workshop, and so we felt very positive about that. So the next step, now once we finished up the workshop and got the feedback from it, now we're embarking on our next phase, which is the actual CMV clinics. And it turns out the first one is tomorrow, and we have 5 children. 4 of these 5 children were present, and their families were present for the workshop. But we have a full day schedule, where we're going to do kind of a round robin evaluation. In the morning, we have 3 younger children who will go through a series of visits with the developmental pediatrician, the OT-PT specialist, and the educational psychologist. So they'll be rotating through at the hearing house. And then we'll meet and triage with each family for about a half an hour to share the findings, give their feedback, make recommendations or considerations for the next step for that child. And then we have a nutritionist from the University of Auckland, pediatric nutritionist Amy Lovell, is going to be present and talk about nutrition concerns. That ends up being an area of concern for a lot of parents, and because of some of the sensory issues and developmental delays that come around CMV, almost all of the families reported that their children had issues there. They had concerns about their children's eating and nutrition. So Amy's going to provide a lecture during lunchtime that we will have all families present for. And so we'll wrap up with the younger children in the morning, and the older children, 2 older children, I think they're age 8 and 10. The first group is age 3 through 6. The 2 older children will come in the afternoon and have a similar format. And our plan again is to repeat this in several months, either with new families or the same families, depending on what the needs are. So the expected outcomes for this whole project, again, it came about in a very organic way, really based on the needs of the children that we were seeing. So this is really a feasibility project. We're conducting this pilot project to see if there's value in extending it to a way of actually managing these children, and if it goes well, then it might be something that we could even actually take to the ministry and see if we could get further support for that. We'll see about that. The second outcome is that we really hope to engage families in networking and advocacy. They can be the best messengers to their own extended family and whānau, and to their own medical community, their pediatricians, just raising awareness about what CMV is, how it's transmitted, sharing knowledge about resources, and just easing the load of bearing the load of dealing with the child's special needs on your own. Sometimes just having a support group or another parent to share that with can be really helpful. So, and overall hoping that the outcomes improve the quality of life for the children and the parents' satisfaction in their care. And then another outcome that we hope to see is that in addition to this clinical relationship, that we can develop some research engagement with the families. And that's sort of where, again, our collaborations with the I Still More Center come in, that we can have some support and expertise in developing some projects. The kind of questions that we have in the front of our mind are things like just describing and quantifying the different manifestations of CMV in our population, how they compare to children who have hearing loss and use cochlear implants that don't have that diagnosis, and maybe how children with CMV that don't have hearing loss manifest, how some of the language behaviors compare. Do children with CMV require a different approach to habilitation? And is a multisensory approach, would that be more effective for children? And so I think our collaborations with OT and PT and possibly nutrition, ed psych, we'll see, may lend some good insight for better ways to manage the children. And then finally, I've added this slide because it speaks to some of the strategic imperatives of the Hearing House. The Hearing House has undergone a transformation of not just having a new beautiful building, but really taking a lead in a lot of different areas that we want to improve on, and service delivery is one of them. And so this project sort of ticks that box, that we want to try to work to improve services and engagement and outcomes, and magnify client voices to inform our program development. And certainly the feedback that we can get from families in this project will be helpful. Research and data is another one of our imperatives, to try to build that within our program and improve our understanding of client outcomes. External focus, so increase the focus on advocacy, community and sector relationships, and again, working with our partners, professional partners, but even the wider community, to share information about CMV and hearing loss is a goal. And then another imperative is strengthening and aligning team culture, and it certainly has taken a collaborative effort within our program, and now extending outside of the program to pull this off and make it happen. And then finally, the technology innovation, investigating new approaches, understanding the potential value and outcomes, and how we can implement that in the Hearing House. So this is a exciting project. It's new. We hope to have updates on it, and more to come and more to share in the future.